Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Hello, everyone. I'm Siri Vaith, Executive Director of CFRI, and I welcome you to our CF Community Voices podcast program and part 2 of our very informative webinar on CF and ototoxicity. We're very fortunate to have 3 experts presenting, Dr. Ahmet Uluer, Dr. Angela Garinis, and Dr. Michael Dewey. It's a great deal of information to share, so this podcast has been divided into 2 parts. In this part 2, we'll learn about ototoxicity screening and prevention, the management of ototoxicity, and future treatments and clinical trials that are in progress. If you wish to learn more about the pathogenesis of CF and hearing loss and the causes of and screening for ototoxicity, please also watch part 1. Please note that the information presented in this recording should not be used for medical advice, diagnosis, or treatment, and to please consult with your medical team before making any changes to your healthcare plan. I want to thank our sponsors. This podcast is possible thanks to the generous support of Vertex Pharmaceuticals, Genentech, Chiesi USA, and Viatris. Many questions were submitted in the Q&A box and answered by our presenters. These questions and responses have been saved and a link provided on this YouTube link and on our website as well. And now on to the webinar. It is my honor to introduce our 3 presenters. Dr. Ahmet Uluer is a pulmonologist and the director of the Adult Cystic Fibrosis Program at Boston Children's Hospital and Brigham and Women's Hospital in Boston, Massachusetts. Dr. Angela Garinis is an audiologist at Oregon Health and Science University in Portland, Oregon. And Dr. Michael Dewey is an audiologist at the University of South Florida in Tampa, Florida. He's also an adult with CF. We will now begin part 2 of this important webinar.
On the right side of the screen, you'll see what we call the audiogram. On the top, frequency, which they say is pitch. So low pitches to high pitches from left to right. And then, as Angie was saying, decibels on the left side from low to very, very loud from top to bottom. So we get this graph of sounds here. The big yellow shape in the middle is what we call the speech banana, where most of the speech sounds of language are. So you'll see the ah and r and ch and sh and all those sorts of things are in a specific frequency range. So they have a specific pitch, and they're also generally specific loudness or intensity. So we have this area where these speech sounds fall. And then also on this chart, we see some different icons for different sounds. Rustling leaves, very quiet. Maybe vacuuming is loud. And so the range from 35 to 60 decibels is generally about conversational speech. So this just gives you an idea of what we're looking at when we see an audiogram. So the standard audiometric test, it's called a threshold test because we're looking for hearing thresholds. And your hearing threshold is the point at which you can hear the softest sound that you can possibly hear. So the standard frequencies that we test are from 250 hertz to 8,000 hertz. And that's generally what you would be tested at any audiology clinic. And for people who are at risk of ototoxic exposure, we test what are called the extended high frequencies. So above 8,000 hertz, so 9 to 16,000 hertz. And those frequencies are super important because those frequencies are the first ones usually to have some difficulty to start seeing the effects of ototoxicity. So if you just do a standard 250 to 8,000 audiogram, you might not be seeing the full picture of any ototoxic damage that might be occurring. So it's important to also test the extended high frequencies up to 16,000 hertz. And so this applies to almost everyone 5 years and over. So once we can get them to understand the task and say, we're going to play a sound, please respond. Either it's a button press or maybe a hand raise, and we do that on everybody. And the second test we usually do is otoacoustic emissions. Just like Angie was saying, we call those OAEs, if you hear that acronym. So that's we play the sound and we record the echo that comes back from the cochlea. And tympanometry, again, she already explained that. And we also use some different questionnaires. So we might have a tinnitus screener, so a questionnaire that asks them to grade different things about their tinnitus, or just questions about their hearing in general, about their balance, how confident they are in their activities and in their abilities to balance. And then also something called a CTCAE, which is a grading scale for the severity of adverse effects of various drugs. It's usually used in cancer treatment, but in this instance, we also use it for ototoxic screening because we're looking for the effects, the negative effects of various drugs that we use to treat people with CF.
Yeah, and I'm just going to add on really quick that, so Mike made the point, the higher the frequency, the better for detection of ototoxicity, and that's when it comes to your actual hearing. So if you're listening through headphones and you're being asked to, respond to a sound, we'll usually test the highest frequency possible. For babies or children, that still remains the same, regardless of age, is we want to test the highest frequency possible, but we're limited to what we can test with our physiologic assessments, that auditory brainstem response test, and also the otoacoustic emissions. And so, so just to note that there is a slight difference on what those pitches or frequencies might be when you're doing an audiogram hearing test versus those other physiologic assessments.
Thanks, Angie. For me, I put in some examples of what my hearing testing looked like when I was in grad school. So I was about 24 when I started grad school, and on the left, I have my audiogram. So you'll see I have nice normal thresholds, 0 dB, all the way through about 4,000 hertz. And then at 8,000 hertz, it dips down a bit. So I put a green line there to show what we normally consider normal hearing, about 20 and lower. So my 8,000 threshold was still considered normal, but it's obviously a deviation from the rest of my thresholds. So when I was in school, I didn't get my extended highs tested. And I actually haven't since. So I don't know what my extended highs look like. Just something that I should probably get tested. But my 8,000 even then may have been showing some effects. And I also put in my OAEs, so the otoacoustic emissions. This graph is a bit different from the one on the left. It's kind of flipped, but the main idea is that the blue line is my ear's response, so my ear's echo response. And the black lines are where that blue line should be. So you can see that the blue line is down, so that green line is what we call a noise floor. So essentially just the ambient noise in the room. And even though there's some difference between the green and the blue, it's not really enough. My blue line should be up around in those black lined regions. So this wasn't my exact OAE, but it's representative of what mine looked like. You could go to the next slide. So like I said before, all these things I was noticing kind of like pieces of a larger puzzle. So especially after the objective measurements of my hearing and OAEs and my tinnitus and the things that were fact for me, I started thinking more about what I was hearing. And I noticed that I was having difficulty hearing in noisy situations. I was in the car with my fiance and her family, and all the windows were open. And I was in the back with my fiance, and the three of them were all having a conversation, and I didn't hear a single word. I really didn't. And I just sat back and I thought, wow, I actually am not hearing any of this, and everyone else seemed to be doing fine. I've recently noticed that some loud sounds that for others don't seem to be a big deal are for me on the edge of painful, where it's annoying and I'll wince at it a bit. Another loud noise situation, I was in the gym, I was lifting with a friend, and there was loud music playing, and I could barely understand him. He didn't seem to be having much issue at all. And the combination of all these things over time, start to realize that, wow, I really am having some trouble that maybe I hadn't thought about before, I haven't really realized. And some extra things during graduate school, I was studying with a supervisor, some vestibular tests, which are balance tests, and she suspected that I might have a mild one-sided balance issue, which she called mild because I don't really notice it in my daily life, but I essentially failed the test that I was doing. And then I also failed a bedside screener test called the Fukuda test, where you hold your arms up and you march your legs. And if you turn, you have your eyes closed. And if you are turning while you're marching, then you fail that test. So I failed that as well. So just the combination of all these different things over time, I've pieced together to suggest to myself that there could be some possible ototoxicity going on.
So we briefly, we've talked about these terms already, and so I just want to briefly mention again that tinnitus, when we say tinnitus or tinnitus, you'll hear it both ways. It's a ringing in the ears, or sometimes people will notice it in the center of their head. It may be a tone, it may be noises. It's something that that someone can pinpoint that is happening some of the time, maybe for 30 seconds at a time, or all day long, where you have this kind of long-term ringing. And so tinnitus can happen because of drug exposure, but also because of other factors related to hearing loss and so forth. So it's one of the common ototoxicity symptoms. The other is permanent hearing loss. And as we mentioned, we test at the highest frequency possible. So we tend to see hearing loss in the highest pitch range that will sometimes progress down to lower. And it may happen in one ear first versus the other. So that's very difficult to predict. One other feature of ototoxicity may be difficulty understanding speech and noise. So I can test somebody in a hearing booth and ask them to respond to a tone in quiet. So if we go back to the audiogram that Mike explained, where you had the speech banana and the familiar sounds, I may test someone who's been exposed to an aminoglycoside like Toby, and they'll have normal hearing thresholds. And so you don't see a hearing issue in the booth. But then that same person may have complaints of listening and noise. So if they're out at a restaurant or, you know, at a concert trying to listen to someone talk, they're having some distortion or concerns there. I'm working with a group, Dr. Patrick Feeney and Dr. Lisa Hunter, who is studying this now, and they just published a paper in we just published a paper in the American Journal of Audiology that talks a little bit about the differences in patients that have had aminoglycosides versus not, who report speech and noise issues. And again, you know, we talked about vestibular balance problems. So the inner part of the ear does have a very important role in making sure that we're feeling balanced depending on the direction that we actually walk or move. So some of the symptoms that someone will report if they have what we call vestibulotoxicity, so toxicity to the vestibular system, is dizziness, which we're mostly familiar with, disequilibrium, which is a feeling of being off balance or maybe not able to remain upright. Oscillopsia, which is a sensation that your environment is constantly in motion, or vertigo, which many of us have maybe experienced, where it's just feeling like you're spinning. And so these are some of the major vestibular symptoms that we would look out for when someone is receiving a drug that we know can affect how the inner ear is working. The most important last point there is that unfortunately at this time, there's a lot of research going on, but we're unable to predict who will develop these symptoms or how they will progress. And so that's why we need to have some type of general hearing and balance monitoring in all patients that receive these medications. This is a really important, I love to show this slide. Ahmet and I talked about this earlier. Especially for someone who, like myself, before I actually was familiar with cystic fibrosis or how a specialty clinic works. For those of you that, and I know a lot of you who are watching have CF, and you're used to seeing all of these clinicians and providers. And the importance there is that, it's a whole body disease that needs to be nurtured and taken care of, and also receive specific treatments for throughout your life. And audiology, although it's important, is not part of that typical clinical care team. There's a lot of reasons that this may be a factor. One is that audiology itself has some resource issues where there's barriers between them having enough resources to support all of these clinical specialties and clinics that need hearing monitoring or ototoxicity monitoring. The other is that a lot of patients are already seeing a number of people in clinic that day, and it's just there's no room to have yet another provider. So we have to think about how to incorporate hearing care and access to patients that need it without putting an extra burden on the clinical team and also on the patient themselves. So this slide just briefly talks about the variability in the literature related to individuals who have cystic fibrosis and their degree of hearing loss. So what do we actually see? We have studies that go back to 1991 and even earlier. And what you'll notice is that this is the first thing I always say, is that the hearing loss that you detect is really dependent on the metric that you're using too. So for example, for children, Chang et al. In 2009 showed that 14% of patients had sensory neural hearing loss who had cystic fibrosis and a history of aminoglycoside treatments. A more recent study in 2015 reported 24% in patients. And then you'll see even in the teens and adults literature that it can range anywhere from 16% all the way up to 56%. And then the most recent publication that we have is that just came out. That was the paper I was referring to, Drs. Lisa Hunter and Dr. Patrick Feeney. So Dr. Blankenship reported that 57% of patients with cystic fibrosis had hearing loss. And this is actually a pediatric study. So if you look at the age range, their patients were 6 years old all the way up to 21 years of age. And so the next point is that, again, we are limited. So Ahmet, if you advance the next one. Thank you. So a lot of the variability that we see is due to differences in not just the patient's clinical characteristics, it's also the metrics. So if we go back to that audiogram and we think about the important sensitive frequencies for ototoxicity, we said we want to test above 8 kilohertz in order to detect I guess some people will say early signs of ototoxicity, but just to detect ototoxicity when it's first occurring. And so if you're not testing that range and you're only testing that lower pitch range up to 8K, you're going to detect a lower prevalence of ototoxicity in the population. And so that seems to be a pretty large factor in some of these differences where you're seeing 16% versus 56% of prevalence reported. The other is a lot of patients obviously receive other concomitant treatments like loop diuretics or vancomycin, which is a glycopeptide, and those might have synergistic effects that could increase one's risk for hearing loss. Most importantly, and I know Ahmet's going to talk about this in a bit here, the total body clearance of the drugs. So some people's systems and their kidneys will clear the drugs faster than others, and that actually plays a role in your risks for ototoxicity. So, and just briefly, and I know in the interest of time, I wanted to just provide some studies on what the reported prevalence is of tinnitus and balance. And in that latest study, a lot of the tinnitus by Chelsea Blankenship, they reported 39% of their patients had tinnitus and 23% reported balance issues via questionnaires. And so we just, we're actually, one of my students is presenting a poster at the American Auditory Society, and I put in this figure here, it's unpublished data, but she's showing about 24% of the patients that we've tested or talked to so far report some degree of tinnitus lasting longer than 3 minutes. And so that's our metric for what's tinnitus, what is kind of a constant tinnitus versus something that's intermittent. So if it's less than 3 minutes, it may just be that few seconds that we all experience. So we're concerned about the tinnitus that lasts longer. And then Janie Handelsman published a paper in 2017, and it's one of the only papers about vestibulotoxicity and patients with cystic fibrosis. And in that paper, the specific metric that she was using showed that 79% of patients had some degree of vestibular system dysfunction. And in the interest of time, I'm not going to go into the actual vestibular testing, but I'm happy to talk about that offline with anyone if needed. One other really important point is that, and I mentioned this earlier, is there's a lot of variability across patients. These are some of the main factors that may contribute to your risk of or susceptibility for ototoxicity. And so these are factors that we're studying and that we need to consider when we're actually monitoring a patient that is on these specific drugs. So how much of the drug are they receiving, the dose of the drug, what other treatments are they receiving at the same time? So again, as I said, the vancomycin or the loop diuretic may increase one's risk. Age is an important component. Pre-exposure hearing status. In some of Dawn Conrad Martin's work at the VA, she's showing that her patients that are her oncology patients who are on these chemotherapeutics, if they started with hearing loss, they actually lose less hearing than those who had normal hearing, who started the drug and developed hearing loss. So your pre-exposure hearing status is important. Your kidney function, genetics, as we've talked about, and then other inflammatory response or diseases may contribute to your susceptibility. So why is ototoxicity management important in CF care? And Ahmet, we could bring up all the points and I can briefly, yeah, and so I briefly mentioned most of these before. It's really critical to identify the patients that are susceptible so that we can monitor them more closely. There's also this other group of patients that I haven't talked about who may never develop any of these symptoms, and they might have ototoxic drugs their whole life, but that's just, you know, we don't know how to identify that person. So it's important to keep monitoring. So, and this again, we can just advance, I'll bring up the whole slide. So this just tells us a bit about the percentage of specialist centers that actually monitor for ototoxicity. And overall, there are some clinics that do it well and others that don't. And as a whole, in the United States, we see a very low number of centers that do it regularly for standard of care practice. As an audiologist, you know, in our professional guidelines, we do consider this standard of care, but it hasn't been implemented yet. And that's something that we do have to work on with the clinics and also with the audiology, the audiologists themselves to develop a program to improve it. So as I was saying, we do have a number of professional guidelines that talk about ototoxic monitoring. They're from audiology professional groups called the American Speech Hearing Language Association and the American Academy of Audiology. And there's specific protocols for adults in terms of monitoring, but it's a very heavy monitoring protocol. So some of the recommendations are not realistic for clinical specialties that where the patients are already burdened with another number of appointments. And one thing to note is that specifically there are no ototoxic monitoring guidelines for patients with cystic fibrosis. Although I know the CF Foundation may be putting, so I've been hearing they may be putting some out here in the next year. So one thing I did want to mention is that we have an international ototoxicity monitoring working group that's come together, and it's a global consortium of international stakeholders from universities, health foundations, professional societies, government agencies, and patients who've come together to work on this gap in clinical management for monitoring patients with ototoxicity and managing any type of hearing loss that's due to not just ototoxicity, but occupational noise and environmental exposures. This group that I've listed here on the left actually co-wrote a paper that we submitted to the American Journal of Audiology that was specifically for clinical considerations for ototoxicity management in persons with cystic fibrosis. So that paper is under review, and we're hoping that will help provide some more guidance to clinicians and researchers that are interested in getting some monitoring going in their own clinics or projects.
So my last little bit here is things that I wish had occurred at my medical visits, mostly my cystic fibrosis visits. So one thing that I never had during any of my appointments were hearing screenings or hearing tests of any kind. I wasn't taking the extremely ototoxic drugs that we know of. I had some inhaled tobramycin here and there and oral azithromycin most of the time, but I was not exposed to gentamicin or kanamycin or any of the really bad ones. But just in general, just being a patient with cystic fibrosis, I think that I should have had my hearing screened at some point. Related to that, I didn't receive any counseling regarding possible ototoxicity or risk of hearing loss at all. And I was never asked about it. I never saw a question on a questionnaire about my hearing or my tinnitus or my balance. So honestly, the first time I ever thought about it, I was already 24. So that's something that I would like to see improved in clinics across the country. I know that many are doing screenings and are more proactive, but I think we probably have a long way to go.
That's right. Well, thank you so much, Michael. And once again, I apologize for all the technical issues. That's never happened before, but anyway, it doesn't make it any better. What I wanted to just share is that we've been doing some research at our center looking at hearing loss, and we knew it was important for us to screen, and thus we created a screening algorithm for both those who are younger than age 18 and those who are over age 18. And I cannot see my slides, so or I can't see most of it, but essentially this is to show that we want to start screening at age 4, and if there's an abnormal audiogram to continue to monitor that. If it's normal and there's no exposure, that we do screening every 4 years. But if there is an exposure, that we get another audiogram within 6 months of the exposure, and then monitor for continued chronic exposures, especially if abnormal. And similarly, this is for those over the age of 18. So essentially, though, how can we prevent aminoglycoside toxicity? So we're going to look essentially at that, but this really, also applies to, I know there's questions on vancomycin and how we can monitor that. But essentially, there was a study, and I'm going to do this very quickly, but we looked at, it used to be that tobramycin was given 3 times a day, and then we went to once a day, and it was a trial called the TOPIC trial. that Alan Smith was the first author of, as you can see here. And essentially, it was a study that didn't note any hearing loss, but it did show that once daily dosing was better for nephrotoxicity. And the type of monitoring that was recommended was a peak and a trough, and maintaining a trough where it was less than 1 microgram per ml, with a peak that was between 20 to 40 micrograms of ml. And essentially, to measure a serum level after tobramycin is infused 30 minutes after the second infusion. Essentially, let me see if I can move this thing. Can't get it out of the way. Anyway, so essentially what we saw was, what we want to look at is that when we did pharmacokinetics, pharmacokinetics were able to show that potentially doing serum peak monitoring wasn't adequate. That once daily therapy, once daily therapy of tobramycin was effective, but we wanted to minimize toxicity, and that when we did patient-specific PKs, pharmacokinetics, that we were able to show that potentially there was a difference in drug clearance between patients, as Angie and Mike had alluded to before, and that maybe measuring peak and trough was missing that. And here we're looking at reported peaks and calculated peaks. So the reported peak is in blue. That's what when we measure a level 30 minutes apart, we're saying that that's what the level is. But when you calculate it, we're seeing that those peak levels were actually much higher. So we're seeing that in the square line there. And when we looked at this even closer, we saw that, and when we looked at just reported peaks, that patients were in the therapeutic level a significant number of time. And if we calculated it, even looked like it was 74%. But when we looked at the area under the curve is the amount of drug that someone's exposed to during the infusion and clearance of that medication. We saw that actually 60% of those patients were super therapeutic, meaning they were getting really high doses. So we looked at 27 patients in this pilot study, and this is 16 of them on the graphic on the right that showed that the peak levels were super therapeutic, and in only 2 of those did the reported peak actually come back showing that there was maybe a level that was too high. So essentially, we showed that measuring serum peaks and troughs, we feel are inadequate, and that pharmacokinetics are really the best way to go. And this is simple to do. It does not involve more than the same number of blood draws as doing peaks and troughs. It's still only 2. You just need to do them at least an hour apart, and to get 2 levels that have a measurable level of the medication in them. So usually we do it around 1 to 2 hours after the drug is infused, and then another one maybe 6 to 8 hours later. Essentially, we think that the more that this type of monitoring, and I'm just going to quickly go through this, is that it is just better. We think that there's probably centers really moving towards this, although maybe 50% continue to monitor just the usual serum peak and trough.
Yeah, so Ahmet brings up a really important point, and the study I was talking about, we have a new R01 that Pat Feeney and Lisa Hunter are PIs on, and they're actually looking at pharmacokinetics as a risk factor for ototoxicity. So it's wonderful that you've done that work, and I'm sure that we'll want to talk to you a bit later too about the project that we're doing. So the next thing you might be thinking, well, what do we do? So if we're not being monitored for ototoxicity, then how do we get that into the clinic? And part of that publication that we're putting out to AJA, and it's currently under review, that manuscript, is talking about point of care and bedside testing. So rather than having all patients go down to an audiology clinic for referral, coming back for a different appointment, there are a series of tests that you can do at bedside or potentially in the clinic, maybe while you're there for your CF care day, where we can do a brief screening of your hearing, of your tinnitus status, or even of your balance. And so this is a table I pulled from that publication, and it just gives, and again, in the interest of time, I'm not going to go over every single test, but it talks about how this test could be administered. So, you know, we do have a lot of portable electronic devices and apps that may be used for the hearing monitoring portion. And then you could have someone that is not an audiologist, but a trained technician or individual to administer these tests without having the audiologist present during the clinic day, but they can interpret the results at a later point. So point of care and bedside testing can be important to implement into the clinic so that you can provide hearing health access for ototoxicity monitoring.
So on that point, I mean, it is true that, you know, getting another test, another screening is a burden on people with CF. I mean, we do so much testing and we ask so much of you. And so, and also, so when someone in clinic is going to go for screening and they have to cross the street and find the sound booth, you know, instead of turning left towards that clinic, maybe you turn right and you get some coffee and you go home. So it is, you know, that screening can sometimes, you know, be problematic. So kind of point of care screening is something that we're also interested in. We did a study with a group that Angie is also familiar with, a company here local in Boston, at least, called Decibel Therapeutics. And we screened using this point of care technology, 72 people, as you can see here, between the ages of 18 and 69. We did a cross-sectional study where we just, you know, recruited people in clinic, as well as monitored serially some patients coming in for IV antibiotics. It was the Career Wireless Automated Hearing Test using these state-of-the-art, you know, headphones, and they're very stylish, I can tell you. And then we used a tablet in our case in order to be able to do the battery of testing that Angie spoke about. And a number of assessments you can see here in the patients that we saw. But essentially, we looked at you know, groups more specifically, and I just wanted to highlight that this is looking at patients who had pre-existing hearing loss. And those who were in the cross-sectional study, there was 56 patients we looked at, and there was 25% and up to 52% that had you know, sensory neural hearing loss or high frequency hearing loss. What I was just going to point to here is that our standard testing, as Angie and Mike alluded to, goes up to 8 kilohertz, but it's really these higher frequency ranges that we saw that we were able to test with this point of care test, that we saw an increased number, almost double the number of patients we caught, up to 8 kilohertz. And in those getting IV aminoglycosides, so the second group, there's no IV aminoglycoside history, but in those with IV aminoglycosides, it was really only, there was a small group of patients that we were able to screen, but it was still a high prevalence that were tested in the high frequencies. But another thing that we found that I thought was really interesting is that when we looked at aminoglycosides, we also included those on IV vancomycin. Now, we didn't see anyone serially have worsening hearing testing when they were getting aminoglycosides. And we really think that this is because of the way we're monitoring pharmacokinetics. So this study was done after we implemented pharmacokinetic testing about 6 years ago. There's also a study that looks at amikacin in treatment of tuberculosis. And it showed the same thing, that you can actually avoid hearing loss, you know, when you are monitoring appropriately. But looking at IV vancomycin, it was that we saw, you know, to our surprise, 60 to 80% of people with hearing changes when serially being tested. So really showing that it is necessary for us to be focused on this. And I won't go through any more of this, but essentially, the point of care testing is critical and provides an opportunity to diagnose hearing loss, you know, much more feasible way.
And so one question might be, well, when you do detect ototoxicity, when do you actually do something about it? And as an audiologist, it's something that, a decision we have to make whether we want to continue to monitor and whether there actually needs to be some type of intervention or management. So the first thing we always recommend is continued ototoxicity monitoring, because if a patient's going to continue to receive similar treatments, they may continue to have progressive hearing loss. So it's important to have your hearing and balance continually monitored. The other thing is if your hearing loss becomes severe enough to where you would qualify for a hearing aid, then we would provide amplification and you would be sent to an audiologist to have a hearing aid program to be able to give you amplification or sound, an increase in sound level at the pitches or frequencies where you have your hearing loss. If your hearing loss becomes severe to profound enough where a hearing aid won't help, you may be recommended to receive a surgical device called a cochlear implant. And so that cochlear implant actually takes the role of those little sensory cells in the cochlear inner ear. And so once those have died off or they're not functioning anymore, the cochlear implant can send stimulation to the auditory nerve through the device itself. Oral rehabilitation is often used for patients who have hearing loss or tinnitus issues that need counseling and management to help improve communication strategies and so forth. And I'd like to mention the Progressive Tinnitus Management Program. It was developed by Jim Henry at the NCRAR, the National Center for Rehabilitative Auditory Research at the Portland VA. And it's used for veterans. Right now, there isn't a magic pill or solution to helping individuals with ringing in the ears or tinnitus. But this program looks at the problem as, again, treating the whole person. And so this little figure here on the right talks about identifying whether the tinnitus is actually a problem or not. And if it is a problem, then what the next steps are for management. And so some of that management has to do with audiology intervention, but the other part could be actually getting, group education and counseling to help manage the tinnitus itself. It's not going to magically go away, but there's ways to help it reduce the effect it has on quality of life. And this last one here is that there may be some techniques that do help, like a physical therapist may be able to assist with balance issues. Sometimes when patients have vertigo, they'll use this specific maneuver. And you see this busy figure here that talks about if you move someone's head in a specific direction, it may change the way that the fluid's moving in those canals of the inner ear to kind of reset the inner ear and help improve balance. There's some studies that show that that could help with vestibulotoxicity and others that show that it might not be effective. So we still don't know. But there are solutions for management once a balance or tinnitus or hearing issue is noted. And so coming to the end of our slides, I do like to show this figure. It looks busy, but I'm going to briefly explain what we're looking at. So this was published in the Journal of Cystic Fibrosis in 2017. And what we did is we tried to figure out what the prevalence of hearing loss was in our cohort of patients at Oregon Health and Science University. And so we're looking at four different audiograms, similar to the figure that Mike had explained earlier. So on the x-axis or at the bottom here, you see frequency or pitch, and it goes from low to high pitch. So the numbers are from 0 to 15,000 or 16,000. And then on the y-axis or the vertical axis, you're seeing that dB level. So how loud did the sound have to be for the patient or person to detect it? And the red line is saying, where is the cutoff for normal hearing? Everything above that red line is considered to be a normal hearing response to that tone at that given pitch. Anything below shows some hearing loss. So this is a group of patients, again, from OHSU. And so we have a lot of variability in what their hearing responses look like across the entire audiogram. So the upper left quadrant are individuals that have had aminoglycoside antibiotics and maintain normal hearing, and their dosing can range from really low to really, really high dosing throughout their lifetime. The upper right quadrant are individuals that have normal hearing up until that standard frequency cutoff of 8 kilohertz. And then if we continue to test the even higher region above 8K, you can see that you're detecting hearing loss in that higher pitch region. The lower left are those few ears that have what we call notches. So their hearing looks pretty normal overall, but then they just dip right below normal at one pitch. And then the lower right quadrant are the ones that we're most concerned about because they have hearing loss across almost the whole frequency range or pitch range. So they're showing significant hearing loss where many of these patients that probably have amplification at this point. So this illustration is showing, and if you just move through the numbers here, you can see the percentages of ears that actually are showing hearing loss. And so this illustrates that, one, we don't know how to identify these individuals, and two, there's a lot of variability in patients regardless of their ototoxic drug exposure. So again, this is another reason to continue monitoring regularly. An important point also is to account for cumulative dosing, which is very difficult to assess. So many patients take inhaled antibiotics and antibiotics through IV, and we're thinking of ways to be able to capture that information from the time they receive their first dose. That will help give us a more better accurate estimate of who's at a higher risk because of the actual dosing of the drug exposure. This is an example of a patient who's 26 with cystic fibrosis. She's been in our studies for over a decade. And in this figure, you see her hearing test. This is the left ear. And in the lower pitch region, she has normal hearing, and then her hearing just completely drops off after about 4,000 hertz up to 8,000 hertz. And then in the next figure, you can see that once she continues to get amikacin treatment, so she has been on IV amikacin, she completely loses her hearing above 1,500 hertz. So these responses here, these little X's with an arrow, mean that there was no response at the output limit of my audiometer. And so this individual went from having good hearing to developing a severe hearing loss to becoming a cochlear implant candidate by the time she finished this last IV amikacin treatment. And she now does have cochlear implants, and they're working very well for her.
So we're going to be wrapping up here very soon. Essentially, there are clinical trials that are ongoing, and one of the ones that that many of you may know about is through Sound Pharmaceuticals called Stop Ototoxicity, and it's in a phase 2 clinical trial as we speak, with, I believe, the national PI is Patrick Flume, and is aimed to prevent and treat the ototoxicity in patients undergoing, IV administration of tobramycin.
And the second clinical trial is for a company called Auricula Therapeutics. They have an agent called ORC13661, which has also been shown to be ineffective in the mammalian model. And they're moving into their phase 2 clinical trial, and they're going to be testing patients, which some patients with cystic fibrosis have this NTM infections, the non-tuberculosis mycobacterium. But we're going to specifically be focusing on that clinical group for the phase 2 treatment. So some patients will receive the ototherapeutic drug with their amikacin treatments, and others will receive a placebo. So these are kind of, I think, the two main companies right now that have advanced this ototherapeutic treatment, so that if you do have to take a drug that we know is ototoxic, it may prevent it from actually causing hearing damage. And with that, I think we'd like to acknowledge a number of people. Specifically, this is my kind of combined list of individuals that have really helped contribute to my advancement in the field and in our research. And so I'd like to thank all of them, and also NIH and the Cystic Fibrosis Foundation for providing funding for our program of research.
And these are acknowledgements that I wanted to share as well. And so thank you very much. I mean, Angie and Michael are the experts here, and it's been really just, I was going to say eye-opening, but hearing opening for me to listen to all the work that you guys are doing, and to do a better job even though we are quite interested in preventing hearing loss, we also really need to improve the screening and monitoring process that we're doing as well. So this is just a great reminder.
What an incredible, incredible presentation. And quite often you can really measure the interest and value and engagement from a presentation by the number of questions. And if people have been watching, I mean, it's been unbelievable, the stream of questions that have been coming in. And I really thank all three of you for answering as we went along, because there's no way we would have had time to ask them. So we do have just a couple more, I think, that are open. And these are ones that came into me that are not in that Q&A, but first of all, thank you to all three of you for raising awareness about this. I am stunned by the statistics in the incidence rates from these recent studies. And I will say, I have a daughter, adult daughter with cystic fibrosis. She's a musician. This has been a terror for her entire life, that it would impact her. And she absolutely has the tinnitus happening. The one question that was answered, but I really want it restated here for everyone, is what people can do in their CF centers to advocate for themselves to have this testing done. I mean, I can say I don't know that she's ever had her hearing tested at any point through her pediatric through adult. So what can people do without seeming, to encourage their care team to start this?
I can just quickly start by saying I know that many centers have, patient and family advisors that are part of their centers, and I think that that's, a great place for people to bring this up if they're concerned. That there is an attention to this. Not every center has access to a sound booth and an audiologist, but there's certainly those in the community if they're not at large institutions. So I think just making everyone aware, like having, more of these presentations and conversations. And I think that Angie and her team that she's leading to bring out a consensus, approach and publications are going to really help with that.
Absolutely. Another question was, can you clarify again the difference between inhaled versus oral versus IV antibiotics and the different impacts for the different modalities? That has been studied between impact of each.
Yeah, so I can briefly talk about the administration mode of the drug. So we do know, because when you're taking a drug intravenously, that you're receiving a higher concentration of that drug, and you're likely at a higher risk for ototoxicity through that mode of administration than inhaled. So when you're taking a nebulizer, nebulized Toby, for example, there are studies now showing that, if you've been taking the nebulized Toby for a period of time, you may be at risk for ototoxicity, but your risks are not as high as if you were to receive regular IV treatments. In terms of the oral, I don't know if we have much data to support whether taking the drug orally, I know there were some studies in the 90s, but I'm not aware of any current data that can support whether or not that risk is the same as IV or inhaled.
Another question that came in, and this was actually prior to your talk, it was someone who couldn't attend today. And it's a woman who's 42, has CF, history of 3 to 4 courses of 3 to 6 weeks of IV tobramycin over a 10-year period, started Trikafta 14 months ago, developed persistent tinnitus 2 to 3 months after starting. So just curious whether there has been, for you in clinic, especially for you, Ahmet, patients since starting Trikafta, if there's been any issues with tinnitus.
We have noted, unique symptoms that are like all of them sort of unique and rare. So I can't discount the fact that the tinnitus may have been enhanced by Trikafta, but I have not seen any such cases, at our center, and we have a pretty large center. But certainly we've seen other, strange side effects here and there. So I think it's something that we should look at, throughout the country to see if these cases are being reported.
And I wanted everybody to know, because we had so many questions, that we are actually copying all of the questions and the answers, creating a document. We're going to denude them of people's names, so you don't need to worry about that. And we'll post it as a link so that following this, people will still have access to those questions and answers. The other thing I wanted to share is that we were having issues. We were hoping to close caption this. We know we had some people who are hearing impaired who are watching. So I do want to clarify that we are going to make sure that this recording has the captioning for people to be able to watch and read at the same time, if that is helpful. And for people who still, this is obviously just the beginning. I feel like you're opening up this Pandora's box in a good way of people having awareness and knowledge and following up on this. And I do want people to know that these wonderful people have agreed to present at our conference this summer. So we'll have even more information on this issue. So is there anything that you feel was not answered or expressed before we end this incredible webinar?
Well, I'd like to, if it's okay, just briefly also hammer home. So what Ahmet was saying, communication is important. And I do want to say that communication is important from the clinical end and the patient's end. So just asking about your hearing or your concerns with hearing loss because of the drugs you're taking is huge. It actually makes a big impact because it cues your physician or the clinician you're working with that you have a concern about it. And so sometimes, one thing that I did is I have a brochure, I might be able to post it, that we give to patients at our hospital. And it's the first thing that we tend to give them if they are receiving an aminoglycoside treatment. So at least if, you're in clinic or you're being admitted, it's something that you can have that's tangible to read, to cue yourself into how to monitor those symptoms. That's the most important thing you can do, is tell your physician if you're having ringing, balance issues, or concerns about your hearing early on. And then from the clinical perspective, again, that publication we talked about, talking to audiologists and doing point of care measures to try to have some type of an implemented program in your CF care clinic would help monitoring patients. We don't know who's going to develop issues, so we want to make sure that we're monitoring everyone to some degree receiving these drugs.
Well, I want to thank you, Dr. Uluer, Dr. Garinis, Dr. Dewing, for sharing your time, your expertise, your personal experiences. This has just been a phenomenal webinar with such a wealth of information, and we look forward to posting this and sharing it so that even more people can learn from it. Again, I want to thank our sponsors, Vertex, Chiesi USA, Genentech, and Viatris for their support that made this possible. And we, as I said, we will release the recording, we will release the questions and answers. And if people do have questions that were not asked yet, please feel free to email us at CFRI, and we will do our best to track down the answer for you. So with that, I thank everybody for attending. And again, thank you to our amazing presenters. I'm very grateful.
Thank you. And thank you, Michael. Thank you, Angie.
Thank you, everyone.
Thank you.
Bye. Be safe and well.
Bye.
Thank you. Take care.
Bye-bye.